Hi, everyone. Welcome to the STMCA podcast. I'm one of your hosts, David Cromp.
And I'm Craig Thomas.
And today I actually got a request, and I thought it'd make a great topic for the podcast. We're going to talk about RSI and actually DFI and the difference between the two. Craig and I had been chatting, and I think it's a good opportunity. So, Craig, do you want to just talk about some of your experiences with RSI and kind of what it means?
Yeah, RSI is rapid sequence intubation, and we're just going to touch on it briefly because it's really something that we don't do in the pre-hospital field because it's kind of a high risk, high reward scenario. Rapid sequence intubation is a two-part intubation by an induction agent first, and then actually a paralytic. And so we're actually paralyzing the person to allow us to try to intubate them. That's what makes it so high risk. And so we need to be able to have all the backups if we're unsuccessful with either direct, we have video laryngoscopes. You want to have all your team members there so that in case things don't go right, you're able to actually get the tube. And so what we usually use is an induction agent like etomidate or ketamine or Verset, and then a paralytic agent like succinylcholine or rocuronium. And it gives us a high chance of success, but it, like I said, does not go without its risks.
Right, right. And so, of note, you mentioned two of the induction agents that we actually carry with us on the rigs, Verset and Ketamine. So if you aren't using a paralytic, which we don't when we're in the field, what you have is something called drug-facilitated intubation, which is just like what it sounds. It's basically using a drug that's going to help you to pass your tube. Sometimes it doesn't necessarily stop breathing, but just dissociates the patient. And we're going to kind of talk about the two common ones we use, both Verset and Ketamine. Now, I love ketamine, so I talked Craig into talking about Verset and kind of how he uses it and what he uses it for.
Yeah, so Verset is a medication that we typically use for sedation and for seizures. It's a benzodiazepine, can be given IM or IV or even IN. But this is a situation where if you're going to be intubating, you want to have an IV established and you want to be prepared for taking this individual's airway. So in the setting of drug-facilitated intubation using Verset, you're probably going to be using about 10 milligrams of Versed. If the patient's a lot larger and hemodynamically stable, you can go up to 20 milligrams. But obviously, the lower the dose to get the job done, the better. And again, as David said, you may still have a little bit of stiffness, but the idea is you're kind of removing some of that resistance to the airway with these drugs.
Yeah, we've all seen it too. You use Versed, and the respiratory rate drops, right? So if you give too much, they actually stop breathing on you, which may or may not be your goal. But if you've got a patient, say somebody with like an asthma exacerbation, who you want to knock down, but you don't necessarily want them to stop breathing, when you want to pass your tube or intubate, ketamine is my drug of choice. So ketamine we'll touch base on in a later podcast, but it essentially works as what's called an NMDA antagonist. And what it does is it just dissociates your patient. So while they're still breathing, they still have respiratory drive, they're not really there. They won't respond to stimuli. Of note, it doesn't necessarily eliminate the gag reflex, so you still run into those problems sometimes. But the nice part about ketamine dosing is easy. If you have an IV, it's 1 to 2 mg per kg. If you don't have an IV, you give it in the muscle, and it's 2 to 4. We like to go big or go home, especially in a case like this. You kind of get one chance to do what you're trying to do. So it's always better to go on the higher end of that spectrum. But of note, it can also be given through an IO, or intraosseous line. Works great, and one of the benefits is that if you've got one of these airways, like I mentioned, asthmatics, it can cause a little bit of bronchorelaxation, theoretically in some of the studies, so it can help you bag easier after you've established your tube. And I think that about covers it for what we wanted to talk about, right?
Yeah, I think RSI obviously is something that we use a lot in the emergency medicine field, but it's something that in the pre-hospital setting, again, we don't use just because we don't have those drugs and it's a high-risk situation. And I think DFI, those are the two main medications we'd be using here at the STMCA. And if anybody has any questions, just get a hold of us and we're happy to answer them.
Always available.